and welcome to COVID-19 weekly clinical rounds. And today's topic is going to be public health measures in the COVID-19 pandemic. Just remind you as you're coming in for you to ensure that you're using your computer audio. We will be muting you to reduce audio feedback. And again, if there's too much feedback from your system, unfortunately, we'll have to mute you. So what I thought we would do today as we're starting is show you a little bit about how you can be accessing information during the WebEx and after the WebEx. And so what you're seeing now is our COVID-19 rounds site. And you can see this is how you came in through the WebEx. The other thing I'd like to just remind you is that at the end of the session, please use this evaluation button, which will allow you to give us some feedback. But more importantly, it will register you for this particular rounds and allow us to keep track of your attendance and then forward study credit certificates to you in the future. As you can see, our presenter today will be Dr. Ariella Zbar, and we'll give you a little bit more information about her in a minute. You can see that you can submit questions between our COVID-19 rounds, and here's a little bit of an idea of what's coming up. And then finally, let me just show you a little bit. Presentation archives are where you'll be able to access previous presentations. And you can see we've already posted Dr. Zbar's slide set, which will be available for you. And finally, this button here, the clinical resources, just want to show you that what it will do is move you to our CPD COVID-19 website for resources. And you can see one of the things we are now doing is tracking COVID cases in Northern Ontario. And as you can see, to date, we have 16, and Dr. Zbar may be giving you a little bit more of an update about that. As well, you can see other resources here. And one of the issues that we discussed a little bit during our last COVID rounds was COVID in maternity care. And as a result, we posted some new resources for you there as well. During the WebEx, if you've got questions, please forward them to us using WebEx chat. And finally, if you are on the phone, you can push your questions to us using our cpd@nosm.ca website. Our planning committee, as outlined there, is that COVID-19 rounds is really responding to emerging information. There's been no sponsorship. And as I was reminding you, the COVID-19 literature is rapidly changing, and our presenters will be discussing the best available information that's currently available. I'd like to introduce to you our presenter today. It's Dr. Ariella Zbar. Ariella is the Associate Medical Officer of Health at the Sudbury District Public Health Unit. As well, she's the Associate Program Director of the NOSM Public Health and Preventive Medical Medicine Residency Program. I'm going to turn over our presentation now to Dr. Zbar, who is coming to us from Sudbury. Ariella.
Check again. Can you hear me?
We can hear you very clearly, Ariella. Thank you so much.
Excellent. All right, thanks everybody. So what I'm going to do is I'm just going to get my content loaded. All right, and just checking again that you can see this NOSM COVID-19 clinical rounds in full screen.
Yes, we can, Ariella.
Excellent. Thank you very much. All right. Okay, so thanks everybody. I know we're all very busy managing COVID-19 now, whether it's in clinical care, in public health, or in other capacities such as educational capacities, and that it doesn't only affect us in our day-to-day jobs, but for for anybody who has relatives or close friends or really is in a community that's we're all impacted in our own way through closures of non-essential businesses or what was deemed to be non-essential businesses, and it's been quite it has been quite a disruptive process from this virus. So I appreciate that everyone's been able on this call is taking an hour out of your time and hoping to make this as practical as possible for particularly for primary care providers. So with that, I will get started. And so just as James had said, I do split my time between public health Sudbury districts, where I'm the Associate Medical Officer of Health, and as Associate Program Director with the PHPM, or Public Health and Preventive Medicine Residency Program at NOSM. Just make sure that this is advancing. Okay. And just making sure that disclosures is showing now. I just want to make sure that this is working. Yeah, great. Okay, so I have no conflicts to declare. Before I get started, I do want to again thank the NOSM CPD for getting this opportunity going. It's always appreciated to reach a broader audience or going beyond the public health Sudbury district's catchment area. And with that in mind, I will just say that I will be speaking more to the more general context of public health management of this for the North. So it's not going to be Sudbury specific. And I also want to thank very much my wonderful PHPM residents, John Tunema and Imran Khan, who have been working very hard on these slides. So I didn't have to as much, which is always very much appreciated. And I just want to acknowledge their work with this. Okay, so an outline. I won't be repeating a lot of what was said last week at the presentation provided by the IPAC team at Public Health Ontario. So I will acknowledge where there's a bit of overlap and where you can reference the previous slide. Sorry, I'm just getting a little bit of feedback. Yeah, thank you. Okay, so I'll be going over public health measures. So what are those? How are they implemented? And just because this a lot of local, provincial, and federal public health organizations or entities have the word public health in it, and it's not something that is taught very clearly, sometimes not at all, in medical school or during residency. So for the purposes of knowing when we say public health, which level are we referring to, who does what exactly, just throwing in that part there at the end as it's relevant to practice. Start with what are the public health measures to address COVID-19. So just as a brief timeline, I think we're all well acquainted with this now that this all came to the foreground in December of last year, and this is a virus seemingly localized to the city of Wuhan in Hubei province, central China. By January, there was a virus that was identified, and at the time it was called 2019 novel coronavirus that was tied to this initial cluster. It began to spread, and by January 30th, the World Health Organization declared this a public health emergency of international concern. This is under what's called the International Health Regulations, and it allows for amassing of and coordination of certain resources and communications in order to, one part of that is to protect countries with fewer resources who are more vulnerable to emergencies such as public health emergencies like this, to give them the capabilities that they need in order to protect their citizens. And by March 11th, the World Health Organization Director General declared COVID-19 a pandemic. And what you'll see in this is there have been a few name changes, as I'm sure you've noticed. It started off as 2019 NCOV, it's a novel coronavirus identified in 2019. The disease is now called COVID-19. The virus itself is called SARS-CoV-2. So SARS coronavirus 2, just to be clear on that. Okay. And to show just exactly how much this has spread, this is from this is a situation report from the World Health Organization. These are all published online. And it shows, this is the SITREP number 3, or situation report number 3. It was the first time that a map was provided in the situation reports, and you can see that with exception, it's mostly localized to China, and there was a bit of spread to Thailand, to Japan, South Korea, as well as non-mainland China, and as well as Taiwan and the United States. Contrast that to yesterday. Really, everywhere except Antarctica is recording cases of this, and where you see this white area here, countries or area or territories without cases, it's not necessarily that there are no cases, it's likely due to not being able to have the testing capacity to confirm cases. So this has spread considerably since it first arose in Wuhan. So in terms of overall global impact, these numbers change all the time. This was just at the time that I finalized these slides and sent them off to NOSM. There's been over 500,000 confirmed cases, over 24,000 deaths. That gives a crude case fatality rate of 4.5%. Just over 100,000 have recovered, and 175 countries are reporting. And it's interesting, when I first started using these slides, it was at a pandemic preparedness session in Sudbury. At the time, the epicenter was still China, and this was just a few weeks ago, and most of the deaths were in China. Now it's Italy. That's where most of the deaths have been recorded, and so the epicenter has shifted to Europe at this time. And so just to really appreciate that this, the spread of this, and what I'm showing right now are the numbers in terms of the numbers of cases. What it does, this is not just what also needs to be spoken to is tremendous societal and economic impact that this is having. It has been a fascinating to see how supply chains have been impacted by this. Something, I'll give an example yesterday, talking about how certain grocery stores are putting up plexiglass barriers between their cashiers, and now you can't find plexiglass in home hardware stores. So it's been a very, it's not just medications that are being affected, it's other types of supply chain. And as of course we know, toilet paper continues to be impacted in terms of availability. So, so just to understand just how much this has spread. So in terms of the Canadian context, back in January, early January, there was the first confirmed travel-related case in Ontario. By March 5th, there was the first case reported of who did not have a known travel or exposure history. This was in British Columbia. And the map that's shown here, and apologies, this should have been dated to yesterday. It shows right now the total probable and confirmed cases across the country, and you can see over 1,000 in Quebec, and just saying this is total probable and confirmed cases. So both laboratory confirmed and those where laboratory confirmation is not available yet. And you can see Ontario and British Columbia are the next two most affected areas, at least from what we can tell from testing and what meets case definition. So, and sorry, before I advance to the next slide, right now we've seen over 2,800 cases in Canada, 28 deaths, and 28 deaths that are confirmed. In Ontario, there are over 600 cases that have been confirmed and 13 deaths. And again, this was just at time of writing. These numbers of cases being confirmed do continue to rise. So when we take that into account, what is being done in terms of public health measures? So last week talked a lot about the infection control measures. I know for those of you on the call, in the clinical realm, you're doing your healthcare measures. Well, what does it mean to take a public health measure or approach to this kind of scenario? So you can divide it into, and this is taken from the pandemic influenza preparedness guidance document through Public Health Agency of Canada. When we talk about these, we can look at personal protective measures. We're looking at community-based measures, or what you would call social distancing, and now this is also being called physical distancing. So we're not trying to say social isolation, but physically separate from other individuals. There is case management, so to try to find and contain and limit the spread of the virus from those who are infected. There are travel and border related actions, and this is where the Quarantine Act that you will have heard about comes into effect. And there's also, of course, public education, so promoting and supporting the implementation of these measures. And so all of these taken together constitute different public health measures. And what I will do is just give a roll up of how this has been playing out at the federal, provincial, and local level, so you can appreciate what has been occurring. And as I'm sure most of you will have heard about flattening the curve or delaying and flattening the curve, that's what we're really talking about here in terms of public health measures. So with the pandemic outbreak, you have no intervention. Again, you have cases, and somewhere along this threshold is where you completely overrun the acute care capacity to respond to this. You don't have enough ventilators. You don't have enough ICU beds. So rather than get into that scenario, delay the curve as much as possible and prolong. So basically, push down on this peak, and what you do is delay the peak as much as possible, and that you try to go below that threshold, wherever that will be, of acute care utilization. So and in doing so, what that means is that you prolong it over a longer period of time, rather than having a high number of severe cases that you won't necessarily be able to treat or save, and that would peak very early, but the impacts would be quite dire on the acute care system. So how this is played out at the federal level. So this is, you will have heard the name Dr. Theresa Tam and Minister Patty Hajdu, and they have been providing leadership in the national response. There is something called the Federal, Provincial, Territorial Public Health Response Plan for Biological Events. Essentially, it allows for coordination of response in this regard, and that's where provincial chief medical officers of health will be linked in with the chief public health officer. And it's not just occurring between the federal and provincial territorial level, but also between the federal government and the World Health Organization, so that they're mutually informed and coordinated in this response. There's laboratory support provided by the National Microbiology Laboratory, which is based out of Winnipeg. And this is our national reference laboratory, where the tests are usually first validated in circumstances like this. We've seen travel advice and advisories, again speaking to one of those public health measures, screening at major Canadian airports, and then there's repatriation and recently more stringent measures around quarantine of Canadians returning from abroad. This has been playing out at the provincial level. Again, there has been a lot playing out, so these are select highlights. In January, the COVID-19 was designated a reportable disease under the Health Protection and Promotion Act. You may not be familiar with this act, but you will be familiar with reporting certain diseases such as measles, mumps, rubella, pertussis, so on and so forth. So once it becomes reportable, that was an important step in making sure that cases could be identified in a timely fashion and thereby contained. And the Health Protection and Promotion Act is specific to Ontario, and it is the legislation that really enables and mandates the work of the Chief Medical Officer of Health and all local public health agencies. It's just important to know that that is the piece of legislation that we operate under. As we know, there have been closures of schools. There was a state of emergency declared by the Premier, and the impact that that's had on businesses that have been allowed to remain open versus not. And March 23rd was the mandatory closures of all non-essential workplaces. So in terms of what the provincial response plan is how it's framed is looking at the initial, well, this is an overlapping phased response, is to contain as much as possible, to mitigate the effects of COVID-19 by decreasing morbidity and mortality, and then recovery is to really allow ourselves to recover and to make the response to this routine within our community. I normally do not put up very busy slides like this. I know it is bad practice, but I just need to show this anyway, just so that what this is showing the various different agencies, particularly with respect to Ontario Health and the coordination that's happening and the different feedback loops there are to the at the very top, the Minister and Minister's office. There's a command table in blue where the ministry sits, Public Health Ontario. It's informed by an emergency operations center, which is in turn informed by a number of players as far as Ontario Health is concerned. For the northern region, so that's both northeastern and northwestern Ontario, there is a regional table that is reporting up in this. So in this very busy slide, it's just to appreciate the fact that there are a lot of individuals involved in the coordination and planning of response or the preparation and response to COVID-19. I've left the link there for you to read more into it because it will take some time to get through this particular visual. In terms of a local response, what I want to highlight here is that local public health acts as a lead agency for community emergency responses when an infectious disease are the cause. And local public health regularly coordinates with the Chief Medical Officer of Health, the Ministry Emergency Operations Center, so lots of different teleconferences and lots of different data going back and forth and questions. There's also the regional, so Ontario Health regional tables, as well as other local health system partners. And I say health system and not just health care. Municipalities, social services, other not distinctly healthcare, but individuals who have sectors that are part of the health sector approach are also being are also working in partnership with local public health. And just in case you don't know which public health unit you're in, there is a locator that I've linked online, and these I've also listed the 7 health units for Northern Ontario, and I'm just looking at this, and I didn't realize I omitted Siluka First Nations Health Authority, just to understand that, just to know that there is a locator tool in case you are not sure which local public health agency you are practicing, or which catchment you are practicing in. I'm going to move on to how public health measures are implemented. And so I'm just going to speed up a little bit. So in terms of physical distancing or social distancing, as it's also called, is basically limiting your ability to, if you are infected, spreading it to others, or you coming into contact with somebody who is infected. So you've heard about 2 meter distance or 6 feet distance, not shaking hands, and just importantly to know that it doesn't mean you must stay in your home. It means that you be careful and that you limit the physical contact and try to avoid crowded situations as much as possible, such as shopping at off-peak hours. And it also, importantly, this does not have to mean social isolation. In terms of what it means for your practice, the ministry has guidance for primary care providers that I've linked below. And there's also additional tips, a really nice document that was published by the Ontario College of Family Physicians. And it's, again, linked there for guidance for in-person visits that talks about putting up physical barriers and plexiglass at your clinic, as well as screening, virtual clinics, so on and so forth. So as we go through public health measures, we talk about social distancing, so keeping people from limiting the transmission or stopping the transmission of this. We also go back to that public health measure of identifying cases and containing them. So how do we identify cases? This was brought up at last week's presentation, and the case definition has remained unchanged, but I've just put it there again for your reference. Testing criteria, on the other hand, have very recently changed as of late March 25th. So testing criteria are no longer based on the case definition, but can be done. So not necessarily will be done, because we know there are, because this will be pending the availability of personal protective equipment and swabs. So it's not based on the case definition, but on a clinical assessment of signs and symptoms consistent with COVID-19. Where there are limited resources, there are prioritization criteria that have been put forward, and I've intentionally highlighted symptomatic in all of these because testing is not recommended for asymptomatic individuals. So where this plays out in your practice, again, if you have a limited amount of swabs, limited amount of PPE, you can, these prioritization criteria can help to allocate your resources. And you'll see that these are individuals, the only thing you may recognize is symptomatic travelers identified at a port of entry to Canada. So that involves one of the exposure criteria. The rest of these individuals, exposure criteria, including as part of the probable case definition, for example, travel and known exposure to confirmed cases. It's not part of that. It's just, are they symptomatic, and are they do they work in a higher setting, or do they reside in a high-risk setting? And it's not just in terms of high risk of transmission, but also high risk of having adverse outcomes of COVID-19 infection. So how the tests are interpreted, because the ordering physician and public health will receive copies of the results. This relies, again, this is on the Public Health Ontario website. It's detection of 2 genomic targets by real-time PCR, or a single target and detection of COVID-19 virus by genetic sequencing. It may be if it's inconclusive, this is sent to the National Microbiology Laboratory, so that reference laboratory in Winnipeg, if needed to confirm. And so again, more information is found on the Public Health Ontario website, but it's just useful to know that it's there so that when you do receive the results, you know how to interpret it. But keep in mind that local public health is always copied on that, and will follow up with patients regardless of test outcomes, so regardless if it's positive or negative. So what do you do when you have a symptomatic individual? What we are saying is that all symptomatic individuals, so symptomatic, we're not talking about exposure history, not going to talk about travel history, symptomatic individuals, they isolate regardless of their testing results for 14 days following symptom onset. If you are testing these individuals, make sure to report that to local public health. And as I said again, we'll follow up with positive, whether positive or negative. There are new criteria that have been put out in terms of how to discharge somebody from isolation. So discharging symptomatic individuals from isolation. It depends if they are at home, if they are hospitalized, or if they are a healthcare worker. These are outlined. Home testing, you do 14 days following symptom onset if afebrile and symptoms are improving. And if somebody has an important detail to that is if somebody has a chronic cough such as COPD, asthma, you don't expect the cough to go away, but just that the symptoms are improving and that they are afebrile. And for hospitalized patients and healthcare workers, we do still rely on isolation until 2 negative tests are taken 24 hours apart. And there's an important caveat for healthcare workers that if if they are deemed critical for operations, and how that is defined depends on your institution or your practice, you can return 14 days after symptom onset wearing appropriate PPE until 2 negative tests are taken 24 hours apart. So moving on to, so we talked about containing the cases, but we also want to be able to find and as much as possible contain the virus within contacts. And this is through contact tracing, which is performed by public health, local public health in most cases. So we look at the period of communicability from 48 hours prior to symptom onset, 14 days after symptom onset, and 48 hours prior to reflect the possibility of asymptomatic transmission. Those contacts are defined below, and then they are there for your reference. In terms of what is done with contacts, so public health will monitor close contacts of probable and confirmed cases. If somebody is in an acute care setting or if they are a close contact who is an inpatient, it will be the responsibility of the hospital, usually through their infection prevention and control team. What we tell them to do depends on their level of risk. So if they are a high risk, so this would be, for example, a healthcare provider who had significant direct care contact with an individual, with a symptomatic individual, while not wearing appropriate personal protective equipment. These individuals will be counseled to self-isolate. Medium risk exposures, and that's to call public health, where exposure levels are concerned. These individuals will be counseled to self-monitor. And if there's no or low risk exposure, it's providing general health advice and reassurance. Some two caveats that are put there, two additional pieces of information that I've included. And in terms of what is self-isolation versus self-monitoring, I do recommend that you visit the Public Health Ontario website. They have posters available for you to print and use in your office. Self-isolation means staying at home, limiting the number of visitors that you have over, avoiding contact with others, respiratory etiquette, wearing a mask over nose and mouth, particularly when you are going, if you need to seek, or if that individual needs to seek healthcare. For self-monitoring, this is monitoring for signs and symptoms for 14 days after exposure. We say avoiding public places as much as possible because if symptoms do onset, it's very hard to self-isolate immediately in a public place. And if symptoms do develop, then we move back to self-isolation. This is the final section of the presentation before I start to take questions. And I just want to speak to, I'm focusing more on the public health role. I know there's a lot of resources, and I will acknowledge there are a lot of resources that are more tailored or are developed by and tailored to, let's say, primary care providers and other providers through resources such as the Canadian College of Family Physicians, the Ontario College of Family Physicians, the Ontario Medical Association, so on and so forth. And a lot of these are done in collaboration with different public health partners. So at the federal level, I just want to be clear again, because again, public health is used, when you say public health, trying to be very clear about which level you're talking about and what the roles and responsibilities are. So there's the Public Health Agency of Canada that acts at the federal level, or this is a federal institution, and this is the Chief Public Health Officer of Canada is employed there, and that's Dr. Tam. The federal government can enact sweeping legislation as it refers to the Emergencies Act. So I won't go into the details, but it does give them quite substantial powers in terms of, for example, using different properties within different provinces and territories. There's also the Quarantine Act, which has been used to apply to returning travelers. Bottom line for primary care is that you check the Public Health Agency of Canada, or PHAC, for travel advice, and there are plenty of resources there that are useful around social distancing, for example, or social physical distancing. And just important that there are national case definitions and provincial case definitions for those of you practicing in Ontario. You follow provincial case definitions for COVID-19. So it's just important to know that there are, where there is provincial or local specific guidance, be sure to follow that, because there may be discrepancies between what is in the provincial or local guidance versus the federal guidance. It's just tailored towards, for example, local epidemiology. At the provincial and local level, so there's a few different players here. So there's the Ministry of Health, and that does include, among many individuals, the Chief Medical Officer of Health, and that's Dr. David Williams. There are local public health agencies, and these are led by medical officers of health. These two, they're the key piece of legislation. So, for example, all of the legislation, basically the raison d'etre for local public health agencies, reporting diseases, shutting down food premises, limiting, and in some cases, and we try not to use this where possible, but severely restricting the movement of individuals with virulent diseases. All of those powers are legislated under the Health Protection and Promotion Act. A key support agency to all of the above is Public Health Ontario. You will know them as the lab people. They operate the Public Health Ontario laboratory, where it's not the Life Labs, it's not the Dynacare requisition. It's that other one. That's the one that goes to Public Health Ontario for those public health or those reportable diseases. And of course, there's partnerships with Indigenous Services Canada, Health Protection Unit Ontario region, who work in step with this for those who, let's say, work within the Sioux Lookout First Nations Health Authority, among other communities. Bottom line for primary care, the Ministry of Health has resources such as health sector guidance documents. They publish and maintain the case definition. They can be contacted for urgent inquiries around personal protective equipment. For Public Health Ontario, they produce technical guidance on testing. That's where you order your testing supplies from them. You submit specimens. They do have excellent best practice guidance on infection prevention and control, as was spoken to last week, and we do have a number of other resources as the scientific and technical guidance that local public health really does benefit from. And of course, at local public health, they're the ones who report cases to, we undertake case and contact management, and we are really there as a general resource and general information for both patients and providers. So with that, and I can't stress this enough, as the epidemiology changes, as more is known about COVID-19, it is so important to stay current with reputable sources of information. And I've highlighted 4 in particular, one through the Public Health Agency of Canada, Ministry of Health, Public Health Ontario, and of course your local public health agency's website, where a number of these resources are already linked. And there's additional communication documents as well as other materials that you will find useful for your practice. So with that, I've reached the end of my presentation and can take questions. What I'll do is I will stop sharing. So
Ariella, it's James here in Thunder Bay. First question, as testing ramps up in Ontario, is the sensitivity and the specificity of the test going to be the same? Is it going to be maintained?
So you mean of the specimens that are used in this? So Public Health Ontario does, I believe, they continually engage in a quality improvement process and ensuring that the types of tests that they do are continue to be valid for use. I know that they are bringing on additional specimens or types of tests that can be used, such as looking into point of care testing and perhaps down the road serological tests. And do it in a way that is both sensitive and specific enough for that, in order to enhance the testing capacity, so that as many people can get tested as would meet criteria. That answers your question.
Great, thank you. We've had some clear guidelines for individuals returning to Northern Ontario if they're coming internationally or coming from the USA. They're supposed to self-isolate. What about residents returning to Northern Ontario from across Canada? We have a relatively low number of cases in Northern Ontario at this point. Should there be any precautions if we have residents coming home from, from Montreal, from Vancouver, as they return to Northern Ontario?
Yeah. So for those questions, your local public health agency may have differ in terms of their approach. In general, if you are a symptomatic individual, you should be self-isolating. So regardless of exposure, and if testing is undertaken, it can confirm if you have COVID-19 or not, but I will just refer back to the clearance criteria that we use for symptomatic individuals, regardless of their exposure history, regardless of their travel history, that they are self-isolating. That is for some cases, but some health units may ask that for asymptomatic individuals, that's a different. So what I spoke to is symptomatic, but for asymptomatic individuals, it will be to in most cases, self-monitoring for 14 days following return from the affected area. So if symptomatic, it's self-isolation. If they're asymptomatic, it is generally to self-monitor. But of course, any questions, I would direct that towards your local public health unit.
Thanks, Ariella. Another question around cases right now. Early on in the pandemic in Canada, we were seeing the majority of cases were travelers returning to Canada. Any sense of what the case breakdown right now in Ontario between travelers and community cases that are not travel related?
Right. So the general estimate across the country is about 50-50, but we do have to keep in mind that there are a lot of, as of yesterday, there were a number of pending test results. So what I say now versus what is in those pending test results, it could be two different things. So it could be less travel and more community acquired, or more travel and less community acquired. Just depends on what's in those pending test results.
Thanks for that. We know that criteria are changing, and I know that you can't predict the future, but one of the questions that's being raised now, of course, is that We're realizing that a large number of individuals are asymptomatic with COVID-19. Does one anticipate that the testing criteria may change in the future, as has similarly happened in Korea, where they were doing a lot of testing of asymptomatic people? Any thoughts on that?
Yeah. So the literature right now, I mean, it is starting to show, or it is starting to suggest more and more that there is asymptomatic transmission, and so inclusive of individuals who are transmitting the virus with symptoms that are extremely mild, so as barely noticeable as a slight itch in the throat. So it's hard to classify if that is asymptomatic versus just very mildly symptomatic. And you will see that reflected in that when we do contact tracing, we go back 48 hours prior to that potential case becoming symptomatic, so that we can find those contacts in that 48-hour period. I will also note that there is the Sentinel Provider Surveillance Network, which is operated through Public Health Ontario. This is typically used for influenza surveillance. They are also being used for COVID-19 surveillance to swab individuals in practices to see if there's community transmission or where there's community transmission. And it could potentially pick up on those mildly symptomatic or asymptomatic individuals. So more research and more data have to come, and where the data would show more around asymptomatic transmission, of course, that would you can expect that would change our testing criteria.
Thanks, Ariella. A couple questions again about the test itself, which you've outlined in terms of what's a positive test. Do we have any sense right now? My understanding is a very specific and sensitive test, but what are the approximate false positive and false negatives for the test right now?
I don't have that information right now, but when that, if that's not already published on the Public Health Ontario website, I believe that should be as they do more of those tests, that it should become clearer as to the false positive rate.
Great, thanks for that. Public health question about small rural hotels. Are there any precautions that small rural hotels who are still staying open and allowing travelers to use their facilities, are there any special public health precautions for small rural hotels in Northern Ontario?
I have to check and make sure that those aren't under the list of non-essential, or that they would actually meet the the first point is, do they actually meet the criteria for are they an essential service, and therefore should they be open or not in the first place? I don't know off the top of my head if they are an essential service. If they are, we do what I would recommend is reaching out to suggesting that they reach out to a local public health unit, because we do have health inspectors who are able to advise around what to do to keep the premises as safe as possible, such as recommendations on cleaning and disinfection of high-touch surfaces where hands and droplets are known to be touched or deposited. And if those are places of business that are deemed essential, I'm not too sure if they should even be open at this point, and I would have to check.
Thanks for that. So you're asking people to, as you're saying, consult their local health unit, and that the inspectors this would fall under their responsibility, and they should be a little bit more up to date on that.
They would be able to do the inspection of that if it is a place that remains open. If it's a non-essential business, then it should not be open in the first place, and that's another matter.
Okay, thanks for that. People are always curious about how things are done. Samples that are obtained in Northern Ontario, where are they tested?
Very good question, and so my answer today will be a little bit different from my answer in a week or 2 more weeks. Public Health Ontario Lab is ramping up testing capacity at various points throughout the province. So they're ramping up not only their testing capacity at the Central Lab in Toronto, they're ramping up capacity in regional hospitals, for example, in Sudbury. And a few others are going to be coming online soon, and also looking into additional ramping up in other laboratory settings. So if it right now, if it's a specimen that's validated for use, or a specimen collection that is validated for use, that can be sent to both the central lab and to the regional labs. But if it's one of those alternate swabs that was mentioned, or alternative specimen collection types that was mentioned last week, those still have to go to the central lab where they are validated for use. And that, of course, will, depending if it goes to a regional lab versus the central lab, and what the priority is on that sample. So, for example, it's an inpatient or healthcare worker that will be prioritized over others. That will, of course, all determine the turnaround time on those specimens.
Great. Another question around, here we've got someone, one of our attendees who's just gone on to a website and has told us that hotels, motels, shared rental units, and student residences are still listed as essential in Northern Ontario. So as you've mentioned, is that they, in the specific community, they should be consulting their local district health unit, and the inspectors will have up-to-date knowledge.
So yeah, and for specific knowledge, and for every health, our websites will also have additional information on workplaces, information for employers, information for community providers around how to maintain a safe workplace. So looking at remote working opportunities, I mean, not necessarily the case in small hotels, but around enhanced cleaning and disinfection measures. So in addition to calling those health inspectors, there's also plenty of resources on websites to consult as well.
Great. Some question here around the usefulness of screening using temperature. So that I think, and you'll correct me if I'm wrong, but the common systems for COVID include a temperature, high temperature with a cough. We're hearing that in certain places, individuals are having their temperatures taken before they board a plane as a screening tool. Can you make any comments around the role of obtaining temperatures from individuals as a screening tool for COVID?
Yeah. So screening using temperature monitoring for travel hasn't been associated with effective containment. So more at the what I take to be at the clinical level. So when we talk to, so what are those screening criteria that basically determine, are you going to see that person, or you can see that person in person versus virtually? Like, how is it going to determine your care of that individual? When we talk about the screening criteria, looking at their temperature or worsening cough or new onset cough. So there's two different things. There's one around traveler screening, which is it doesn't have a lot of evidence to be effective. And there's also, how are you screening in terms of who are you going to see in person versus remotely for your practice.
Thank you for that. We've got a question here around PPE, and I'm not sure whether you can answer it, but let me throw a note at you. Okay. Is there any specific PPE that should be used for routine care in inpatient care in Ontario for non-COVID suspected patients? So PPE for routine inpatient care in a hospital in Northern Ontario for a patient who's not suspected to have COVID-19.
Right. So that's going to be driven by your point of care risk assessment, and so it depends on what their symptoms are, or mostly driven by what their symptoms are. And the best document for that is, I would point again to the Public Health Ontario PIDAC documents. So those were mentioned at length, or discussed at length at last week's webinar, and they go through in detail so if that individual is coughing or if they're having gastrointestinal symptoms, that is going to then determine what your personal protective equipment should be based on your risk assessment before you go into the patient's room.
Question about COVID swab supplies. Are the swabs readily available in Northern Ontario? Are we facing shortages already? Do you have any information on the availability of the COVID swabs?
So I will say more swabs should be coming in a few weeks. The federal government is doing their best to acquire more. There's local manufacturers that are being retooled to develop most of these. It is unfortunate that one of the major suppliers of NP swabs is based out of Italy, so you can understand there will be a significant shortage from that supplier. So there have been issues in getting enough swabs for everyone, and the priority right now is towards hospital or to acute care settings. When that will be freed up, I can't speculate right now, but it will be several days at least until we can see more swabs coming into to use for primary care.
Thanks, Ariella. Another question from an attendee. Are there any special precautions that should be taken for the body of a deceased individual who has presumed COVID-19?
Mm-hmm. That's a good question. So universal precautions would apply in those cases. There are, I can send it along later, additional guidance for those for funeral. There's some guidance for funeral directors, but in general, it is universal precautions, so contact precautions in those cases. But if there is a suspicion that you need generating droplets or aerosol, that would, of course, guide the PPE that you use.
Great, thanks for that. We're just getting close to our 1:30 stop time. So just a reminder to our attendees about completing their evaluations. As well, I'm just going to go back here to our COVID website for a sec. And as Ariella had referred you to, last week's presentation does have a resource handout from Public Health Ontario, which would cover some of those questions that have been asked. Encourage you again to go to our Rounds COVID site to complete an evaluation, and that's how you register for the session to get study credits. And then finally, the other thing I'd like to point out to you is we'll be returning next week, April the 3rd at 12:30 Eastern Standard Time. Our presenters will include Dr. Sarah Newberry, who's a rural family physician in Marathon, Dr. Mike Scott, who is rural critical care coordinator at Thunder Bay Regional. And the topic that they will be exploring together with us is as we provide COVID-19 care to patients, so patients with COVID-19 who require critical care, what are some of the clinical and ethical decision-making strategies and frameworks that we might start to want to look at? I think we're well aware that we're in a time of possible limit on the level of care that we can provide due to both resource issues and human resource issues. And so that looking forward to Dr. Newberry and Scott sharing their thoughts on this. Ariella, I'd really like to thank you for joining us today. As mentioned, your PowerPoint slides are now available on the website, and any further resources that you do push to us, we'll ensure that those are posted by Monday or Tuesday next week. Last word to you, Ariella. Any closing thoughts?
Just thank you again for letting me present today, and I'm happy to share my email as my work email is also on my questions. I email on those as well, just to so thanks again.
Thanks everyone for your participation today. Have a good afternoon. look after yourself and care for yourself as you care for patients in Northern Ontario. Thanks so much for the questions that have been provided today, and we'll see you next week. Bye then.